Thank you so much for inviting us to come speak today. It's really a great honor. David and I are going to tag team this in much the way that we tag team our teaching to the medical students. So it's something we have a long history of doing together, so hopefully we'll be somewhat seamless in transitioning back and forth. From hearing my bio, most of you probably have no idea how I come to be standing here teaching this topic, especially my boss who came to watch today, who has absolutely no idea that I do this in my other life. And sometimes I ask myself, how did I get here teaching this topic today? It was a lot of serendipitous actions that brought me here. We're going to talk a little bit about that process, but it's something I'm incredibly grateful for because I think it's made me certainly a better person, but for sure a better doctor by learning about this topic and by learning from David. So without further ado, we're going to talk a little bit about spiritual care in surgery. Can it be taught? This is based on work that we've done really for the last 2 years in the surgery anesthesiology clerkship. A talk that David and I gave to the national meeting for healthcare chaplains in New Orleans. And then we'll show you at the end a publication that we've now published in MedEd Portal. We have no conflicts of interest. So many of you, know the curriculum in the medical school far better than I do, but I wanted to show you a little bit of the trajectory that this topic has taken and where our place in this is. So when we started this, there was really only kind of touchdowns in ASM 1 and in ASM 2 in a small part in the material that was being taught. And thanks to the efforts of David, there's really been incredible push through the entire 4 years of the curriculum. Now looking at clinical sites in the second year in spiritual care and a spiritual care elective, and you can see where we fall. So there was, at the time we started, there was really nothing on this topic after the first 2 years. And a group had gotten together even before I got involved to kind of postulate where this could go in the next 2 years, and we kind of fell upon our clerkship, and we'll talk more about that in a moment. Just a little bit of background, what we're going to talk about. We're going to review some of the literature. To me, this was really important in my evolution because although, as I just shared with the students on Monday when we taught our session, it obviously seemed like a nice thing to do for patients, I didn't necessarily always know that there was evidence-based material backing up the reasons why this was so important. So we're going to go over some of the literature in the field, how we came to this training initiative, a description of the actual session that we teach, and then some of the assessment of results that we've come up with. So David's going to take you through the literature, which he obviously knows better than I do.
Well, first let me say good morning and thank you. It's fun to be here. When I went to seminary, never imagined myself standing in front of a room full of doctors telling you about the literature review. And I usually get jokes about the priest, the minister, and the imam, and now it's the priest, the surgeon, and whatever else, my boss, Deb, who's a psychiatrist. So it's a fun bit of professional fulfillment. I was reading some articles last night. Dr. Rip had written one recently, co-authored one in academic medicine, and I came across this term of professional fulfillment, and I think it accurately describes what I feel being in this role. So it's a pleasure to be here today. So let's talk a little bit about what the literature says. In a nutshell, it says that patients really want their doctors to ask them about their spirituality, but most physicians don't ask. In one study, 41% of patients said that they would like to be asked, and only half of them had been asked or had some discussions about religion and spirituality. Interestingly, Balboni and others found that physicians desire to have religious and spiritual conversations with their patients, but they don't, primarily for 3 reasons. They believe that they're inadequately trained, or you may believe this, that they don't have the time, and they feel personally uncomfortable. I think all of that probably, it makes sense to me. I imagine that it may resonate with those of you who are physicians in practice. And a long time ago, before any of these articles were published, medical educators recognized this gap. And coursework on religion and spirituality is now widely included in medical school, both undergraduate and graduate medical education programs. Up to 90% of all U.S. medical schools have this kind of curriculum included, and over 50% of colleges of osteopathic medicine. a very important article, well, a very important researcher, Harold Koenig from Duke in 2010 reported that 73% of medical schools now include R&S content in required courses. It doesn't mean that 7% of the religion and spirituality and health is a required course in only 7% of the medical schools. So there's content included in other required courses, but not a lot of required courses. And the content typically is related to the role of spirituality in health beliefs and practices, physician prayer with patients, which is something that Susan and I and our team addresses in this particular session with third year, appropriate professional boundaries, how to take a spiritual history, which is something we've included throughout all 4 years of the curriculum here, and the role of healthcare chaplains, which I think is probably the most surprising part of the curriculum. Is we find there are so many misconceptions about chaplains. Some think that we're volunteers, some think that we're, at best we're volunteers, at worst we are evangelists trying to preach our views to people, and many are surprised to find that we're board-certified professionals who are specially trained for this kind of work. So let me kick this back to Susan, who's going to review the literature for surgeons.
So I'm sure that this statement is not shocking to most of us, if not all of us in the room, right? That it's unlikely that surgeons are doing this. They're certainly doing it less likely. So if all doctors are doing it very little, we can only imagine how little surgeons are doing it. Another literature review that was done showed that surgeons rank underneath all these other types of doctors as far as, who's having these discussions with their patients. There's not a great deal of literature on spirituality and surgery, right? So surgeons are not talking about it. They're certainly not writing about it. They may or may not even be thinking about it. So this is some of the literature that we review with the students in the course as well. But one of the articles I found is probably the largest assembly of looking at these. This is a mixed population of general surgery and orthopedic patients in the University of South Alabama, right? So, of course, the first comment from the students is always, well, we're nothing like South Alabama. Okay, but what I tell them is that even if we're just a little bit religious, right, if we think we're so far different than people in the South, then maybe just a little bit of this data carries over to us. And so they looked at particularly what are patients looking at in their doctor and their surgeon-patient relationship in reference to spirituality. And what they found was, first of all, nearly 70% reported that they pray daily. Of these, 93% reported that the religious beliefs and faith were important to them. And 86% said that they relied on those perspectives to guide them through a major illness or injury. So you can see the national average of people praying is about 60%. So you might say, okay, it's higher in Alabama, maybe it's a little bit lower in New York. I would venture to think that it's not zero in New York. And even if we think, we're a pretty, David likes to point out that we're not as non-religious in New York as we think we are, okay? So there's probably something from this that we can take with us. And what they found that I thought was really, quite shocking was that of the patients that they interviewed, 83% thought their surgeon should be aware of their spiritual beliefs. Right? That's a huge number. They want the surgeons to care, to ask. 63% thought they should take a spiritual history. 64% thought they should refer patients to chaplains. And 64% thought that it would increase trust in their relationship, which to me was the most important piece of data, right? Because I always think patients are going to form their trust in me based on where I went to school or what I look like or whether or not I wear a white coat or whether or not I'm male or female, right? The things that I worry about when I go in to meet a patient and talk to them about their surgery, it never occurred to me, and I certainly was not asking about their spirituality. And yet this is a big component of what patients, may be looking at and forming their relationship with their surgeon. Whatever little literature has been written in surgery is mostly around cardiac patients. You can imagine, right, if your heart is stopped and you're being run on a pump, you probably have a little bit more thought about God and your mortality and maybe turn to prayer even if you never did before. But what they found was that 96% of cardiac patients said they use prayer as a mean of coping, right, which is enormous. And important for us to know. And of these patients, 97 believe that prayer helped them cope more effectively. But in addition, right, and so I always say to the students, right, I have an article for everybody, whether it's you think it's important for patient satisfaction or whether you think it's important because it saves the hospital money. These are metrics that I get tortured about every day in my other jobs, right? Complications, length of stay, mortality. If patients praying and us addressing their spiritual concerns can help that at all, wouldn't that then be something that's worth us looking at? So what did we do now once we knew this was important, or the rest of the team convinced me that it was important? We all worked then to kind of integrate this into the curriculum, and David's going to take you through that journey.
So this process actually predated me. A predecessor of mine was involved with a team that Susan was, eventually a part of. Ed Poliandro, I think, spearheaded this, so Ed, thank you for being here. Joe Trulio and Holly Atkinson, who's now dropped off the team, and we've added Stacy Leisman, who's become a really helpful partner. But the overarching objectives were to integrate spirituality and health across the 4 years of the curriculum, which we've now achieved, to improve culturally effective patient-centered care and to support the well-being of healthcare providers. So we're really moving pretty well according to those objectives. Here's the team that we mentioned. We also had some consultation from the Tannenbaum Center. And this was our process of collaboration. I'll go through each one of these steps here momentarily. And again, much of this preceded me, but what we did was the team began reviewing what was already in the 4 years of the medical school curriculum and identifying whatever gaps that there were, and then designing programs. I'm not sure exactly where we got in first, but we got into the ASM year one with a simple 60-minute lecture on spiritual history, and then from there we kind of moved on. At some point, the clerkship directors were surveyed, and to our good fortune and to her bad fortune, I think, Susan was the one who kind of raised her hand and said, well, I'd be interested in discussing more and perhaps doing more. And so that's how we got our way into the third year.
I thought I was being nice.
So because of her kindness, we were able to get into the third year surgery anesthesia clerkship, and we went on to develop this 60-minute session, which I'll show you the details of momentarily. It's a co-facilitated team within a team. So Susan and I are the faces of the team. We're the two who are sitting up in front of the students doing the talking and speaking, but behind us is that team that I just mentioned a moment ago. And after each session, we get together and debrief, talk about what worked, what didn't work, and look for enhancements and improvements, and also based on student feedback. So there's been some evolution over the course of the session. So what does the course and the content include? If we look at Kolb's cycle of experiential learning, it begins with a concrete experience, moves to reflective observation, abstract conceptualization, and active experimentation. So we begin with the lived experience, the concrete experience of the students in the context of the clerkship interacting with physicians and other team members and patients. This has been enhanced significantly. We don't know what it'll look like next year because now we have second year as a clinical site. So all of the second year students are rotating through spiritual care through a Wednesday afternoon. So everybody who attends this session next year will have had 3 to 4 hours with a chaplain. So this will really enhance their concrete experience, and we're anticipating that we'll have to adjust the session accordingly. And then we engage them with some reflection, some self-reflection through a series of questions at the beginning, and then, of course, some discussion throughout the course session. We offer them new data similar to what Susan just reviewed with you, what's in the literature, some new frameworks about how to think about spirituality and spiritual care and the physician's role, and then active experimentation through some case discussions. And in other parts of the medical school, they get to apply and practice the FICA, which for those of you who don't know, that's a spiritual history tool that Christina Pulkowski developed that is included in the social history. So here's what the session looks like. We begin with a self-reflection worksheet where they may or may not respond outwardly to these questions. And at one point, we were using poll everywhere cases. Now we just do it old school and just ask them the question and they raise their hand or not. We go through the key data that Susan reviewed and invite them to reflect on their own experience, if they've had any experience with patients who've requested prayer or wanted to find a chaplain. Have they consulted a chaplain? We review FICA, which, again, we go over in the first year. By the third year, the recall on this is pretty low. So it's a refresher in the best sense of in the most optimistic sense of the word. And then we talk about the training of chaplains and the role on the team. This helps to dispel many of the misconceptions about chaplains. And then the nuts and bolts of how to consult and collaborate with spiritual care. We go through some case discussions, and then we revisit the initial questions that we asked, and then take their questions and wrap up. So here's an example of a case, and we can have some fun with this. You're performing a pre-op assessment of a patient in the holding area. You're not familiar with his faith tradition. The patient asks you to pray with him prior to his surgery. What do you do? So this is one of the questions that we ask at the beginning and the end to gauge where people are. So the first option, you can follow the patient's lead during the prayer. You can abstain from the prayer but remain in the room. You can refer to spiritual care, offer to lead a patient in prayer from your own tradition, or make up an excuse to leave the room. So we endorse numbers 1 through 3, but not 4 and 5. And we highlight the asymmetry of power between the physician, particularly the surgeon, and the patient. And so we never want to put the patient in a situation where the patient feels like he or she cannot say no. And so if a physician were to say, well, let me offer a prayer, maybe it'll lower your anxiety, my assumption is that it'll be very difficult for that person to say no, even if they don't want that to happen. And of course, we also emphasize the trust building that can take place through discussions of spirituality. And making up an excuse to leave the room is not going to aid in the trust building, so obviously we don't recommend that. A second and very interesting case is a 25-year-old cisgender woman was injured in a burn. She requires a skin graft but declines the operation when she's told the graft will be porcine. So then we ask these questions: what potential spiritual, cultural, and medical issues are at play, et cetera, et cetera. But I'd love to hear from you if you'd be willing to engage. What kind of observations or insights or thoughts would you have on a case such as this? Great. That's exactly one of the ways we respond to this case is perhaps the patient's Jewish, so we want to find out if this is a religious prohibition. Perhaps the patient is Muslim. And one of the fun things, well, let me ask you, if the patient's not Muslim or Jewish, what other considerations would you think of? Exactly. It always comes up, and it's a great point. This person could be vegan. We had a new one on Monday where somebody said this person could be an animal activist, right? And that's all within the broader concept of spirituality. It may not be a clear religious belief, but it may be a deeply held value that's very important to this person and helps to frame their worldview, and they want to live faithful and consistent to that. So we really want to unearth that and help fold that into the conversation. For people who are Jewish or Muslim, then we could, the surgeon might want to refer to a chaplain to have some more conversation because there's a plurality of views among adherents of both of those religions, and they might be able to flesh out something important with the conversation with the chaplain. And it also may be that using our connections to the community and other faith leaders, we could bridge the gap and bring in somebody who could speak authoritatively to them to help them understand, because not all of us completely understand 100% of our own religion if we are religious. And so we may have misconceptions about our own religious beliefs and practices, and we need some more consultation about that. And then we open it up to other important questions. What stereotypes do you have about chaplains? Does spiritual care carry some hidden meaning to practitioners which makes them wary? What does a chaplain do in practical terms, and what does a chaplain's note look like? So all of these are interesting questions to the students because it gives them the opportunity to say, as I said earlier, oh, I didn't know that chaplains were actually employed by the hospital, or that they had some sort of board certification process. And a lot of people will say, I thought that chaplains were all Christian. It turns out we're not. I thought that chaplains only showed up at times of death. That's not always true, although we do. We're very good at times of death. And then Susan has taken to do this, reading chaplains' notes, which has been very gratifying to me as a chaplain to hear somebody value our notes, because we really agonize over writing those notes and hoping that they're useful and that they're actually read and that they contribute some value. And we've spent a lot of time as a center working on standardizing the way that we write notes and all of that. But Susan will read these and to give a flavor, a sense for what does the chaplain visit look like through the note, to give a view of the diversity of interventions. And in some cases, and I don't mean to minimize what we do, but the simplicity of interventions that are often experienced as very effective by patients. So I think it's time to turn it back over to Susan.
Just one more, I mean, for me, the part, so there's a few parts, and we'll talk about this in a few slides. Like like David had mentioned at the beginning, it was a big process of revising and revising and revising, and we poll the students with every session, and like David said, we meet after every session, and so it's constantly a work in progress, and I am so proud of that because it allows us to really figure out what clicks with the students, and the parts that I have found that they really need to hear over and over again is, you know, exactly like David, what does a chaplain do? Where I have some value as the one who teaches it is that I share a lot of their wariness and lack of experience and wariness again about calling chaplains, and I relate a lot of, you know, real world examples. The notes have been amazing to me because they're all notes on my patients. So I might not have, in most cases, it's not a doctor who called for the chaplain consult, although we're teaching the students and doctors to do this. But, you know, they're incredibly powerful, like he says, simple, but incredibly powerful interventions. In fact, I read a note on Monday, and when I read it, this was the first one that I actually called for the chaplain consult. And when I read the note after he came to see the patient, I cried in my office because I was so amazed, not because the note was sad, but it was so perfectly what the patient needed, that nobody else could have provided for her, not any of us on the team. And then I was kind of amazed when I read it to the students again on Monday. I cried again which was more embarrassing, but it just brought home the point of this. If there's one thing we're trying to teach the students, it's that it's another resource to provide care to the patients in a way that we all are incapable of doing, either because we don't have the skills, we don't have the time, we don't have the interest, and it was so powerful to me. So the question is, are the students getting it, right? Well, how did they evaluate the sessions? And we tried to get some concrete data. This looks at the first 14 months of us doing the session. We've been doing it for about 2 years now. At the time we got these results, we'd given it 10 times. So to give you a little context, there's 8 modules that go through the clerkship, so about 18 students in each module. When I had originally told our team that we would be teaching a group of 18, they were horrified. They could not conceive of teaching a group that was so large, this topic. To make it even more effective, I think we've now combined groups, and we're now teaching to 36, which I personally think is working even better because you need a lot of people in the room to actually have a few who are going to talk up and get involved, and it kind of, I think, gives movement to and energy to the rest of the group. So if it's only gotten better with a bigger group. So these are the people that we've surveyed. Within 2 days of the session, we sent them a survey, just a red cap survey. It was 3 questions. And then the findings were really overall that the course was consistently well received by the students and indeed changed some behavior. So like I said, it was 3 questions, including 1 open-ended question. We had a response rate of almost 73%. 82% said either above average or excellent for the session. 98% thought that it was somewhat relevant or very relevant to patient care. And then some of the qualitative data, we just asked them to give any comments. And of the 120, 115 actually wrote something, and we have just a few of the quotes here. Far and away, they liked it. I was terrified, for sure, the first time I taught it, and then a few times after that, just to look at these like 18 blank looks when I tell them I'm going to teach them about spirituality. They all look at me like I'm as crazy as I think, or I thought I was at the time to be teaching that. And so to get back some of these comments was really gratifying that it was getting to them somehow. Again, it's hilarious that if I weren't an ASM 1 teacher, I wouldn't know. It wouldn't be so funny, maybe. We teach them the FICA, like we said in ASM 1. When I look out, 0 out of 18 have any idea what I'm talking about when I mention the FICA. We're hoping now that they go to do the spiritual elective, the clinical site with David, they'll at least know what a chaplain is. But I have no worry that they're going to be any better at the FICA by the time we get to them. But we teach them really concrete things like how to find the on-call schedule for a chaplain in Amion. They had no idea that there were on-call schedules, that there's chaplains, that it's in their app. So some really concrete things. And then, you know, this was really gratifying, obviously, that they thought that it fit and that, you know, I try and emphasize to them this is a 1-hour period where we're all just going to slow down for a moment and talk about something very different than we do in the other 8 weeks. And it was nice that they appreciated it. And then we decided after, maybe a year doing this, that it'd be worth looking at longer data to see, did it have any lasting effect, or is it like teaching the FICA that they forget the minute they walk out the door? And this was a little bit more lengthy survey that we sent out. We asked them whether or not they still thought it was important. And you can see that far and away, they thought either agreed or strongly agreed that this was an important part of patient-centered care. Did they themselves integrate this into the management of their patients? And so you can say, there was hardly anyone does it almost always, but I wouldn't expect that. I've been teaching this for 2 years, and I can't say that I would say I do it sometimes is how I would rank myself. And so I was pleased the majority of them, touch on it sometimes. And I think that's okay. That's enough to aim for at the moment. If it's on people's minds and they're, addressing it sometimes, I think that's a good goal. Have you used the FICA tool? Still no good with the FICA tool. I keep telling you, I'm not a convert to the FICA tool yet, but if we can teach them some familiarity with the language, I tell them it's a lot like asking sexual history or, intimate partner violence questions in ASM. Everyone has a different comfort level with different language, and you just have to practice it. Do you understand the role of the chaplain? I think we've made good progress in having them understand, who the chaplain is and how to consult them. And have you called a chaplain? And so this is impressive to me, right? Over a third of students have actually called a chaplain. The one other point I really try and drive home is that this is the one consult you can call as a third-year medical student, and I can absolutely guarantee 100% no one will yell at you for calling it, and no one on the other line will yell at you for how you called it or who you are or what lack of information. And it is hard to convince them of that. And the surgery clerkship is a perfect place to try and teach them that because they're afraid to breathe on the clerkship. So they're a little bit skeptical that it's within their realm of skills to be able to call a chaplain. And so I think that's important for them to start trying out. And then overall, has this improved your approach to patient care? And I think, the majority of students thought that it had. And so we were pretty gratified with the results. Again, lots of great qualitative comments. They were happy. They thought it was useful. So what have we learned? Why this clerkship? Still a great question. It makes more sense the longer we teach it. For sure, this is easier to teach elsewhere, right? And of the negative comments, either that I get from the clerkship reps, if they're brave enough to tell me, or in some of the, written feedback, is there still a few people who don't understand why is this in the surgery clerkship? They get this on PalCare, right? They see a chaplain on PalCare, they get it for a week, that's good enough for them. And we are never really going to sway those people, right? But I think that one of the things about teaching it on the surgery clerkship is that if you can teach it here, right, you can teach this anywhere. If I can convince students that they can do it on surgery, even if and I think the hardest barrier we have is that they don't see it role modeled. And that's obviously, like a long-term goal. But if they start to learn that they can do it and they have the power to see where this is useful, I think we really have had an impact. The idea of team teaching has been incredible to both of us. I think if I speak for both of us, we sit up in the front of the room in 2 chairs side by side. We go back and forth. Sometimes I feel like we're doing, like a morning news show, because I think we have a pretty good relationship back and forth. And, some crazy question always comes to mind that I'll ask David, like the day I learned that he doesn't actually go to church every Sunday was fantastic for me. And I think, the students were equally excited to have that asked, right? And so sometimes I'll ask the question in the room that the students might be afraid to ask, or share stories about my own life as a patient and where I think a chaplain might have been helpful. And trying to model this behavior that chaplains can talk to surgeons. One of the things that we found so interesting when we went to the national meeting was that, the chaplains in the room were amazed that, there was a surgeon that someone could talk to. So he can talk to me. I'm allowed to talk to him. There's not a hierarchy between us. I do now read the chaplain's notes. So I think it's helpful for the students to see it modeled even in that small venue. And like I said, we continue to have several iterations of the course. The things that we changed over time, this was much more kind of generic and broad when we started, and we realized after the first few sessions that the students knew nothing about what a chaplain did. So we needed to make it very basic, back to the training and the misconceptions. more information about the literature. I found that I needed to read more literature if I was going to teach this convincingly, and I figured that the students probably would want to hear it if they were going to want to buy into this. And then again, like I said, counseling them that they can do this. Physically telling them, how do you pick up a phone and call? What information do you need to put in EPIC? We all know that they're very granular and they want that. Lots and lots of future directions, right? We continue to meet monthly and try and figure out what our next path is. There's a lot of the feedback that we have not incorporated. For anyone who knows me, I hate role playing, so we have not incorporated role playing into this. I've also not expanded the time for the session, right? We all know the students don't love didactics. Even if this is a fun session, to have them sit there for an hour and a half or 2 hours is never going to fly. So the idea is where to do more role playing and how to do this. I think one of our next steps is we need to expand our vignettes as the students are becoming more sophisticated and know a little bit more on the topic. These are easy cases for them. They don't really think this is so odd or weird when we show some of these cases, which is great because it means we're having an impact in the earlier years. So I think we need to come up with some more challenging vignettes. They want very much to hear from patients. They want us to bring patients in to hear, to see a history modeled and to hear how this has impacted patients. And the question is really, do we do another session within the surgery clerkship? Do we put this in another clerkship? It's hard to put it in another session, another clerkship, because there's no standard order to how the students go through the rotations. So we could have a, spirituality session A and a session B, but then we have to have 2 sets of faculty who are able to teach 2 different sessions. So we're still working on that. And then slowly making their way into the GME curriculum. We've talked to Mike. David has started working with primary care residents and giving some of the same curriculum to the residents because they didn't learn it in medical school and don't have the skills. And then our bigger thoughts, and Anu and I have spoken about this, what is the role of spirituality in the healthcare system? How can it shape the lives of practitioners? Is there a role in wellness and burnout for the students, for the residents, for the doctors? Where else do we go with some of these topics? And like I bragged about at the beginning, we're very proud of being able to publish our work into MedEd portal. Thanks to Holly for any of you who've worked with Holly Axton, a great taskmaster. Now that she's left our committee to go to CUNY, it's going to be much harder to get anything published. But it really was a great group to be able to put this out together.